All right, welcome to the last of our blood lectures. This is going to be blood part 4, and we're going to talk about leukocytes, thrombocytes, and hemostasis. So, as always, let's begin with our not really attendance questions for the day. And you can see this one is a little bit more detailed than our previous ones. This is actually kind of a case study. It's going to require a little bit more critical thinking, and I'm going to throw these in here and there because these will actually force you to apply more of what you've learned rather than just answering straight out a question. And I do use a lot of case studies on exams, so get used to seeing stuff like this. Let's go ahead and read this question, and as I'm reading it, make sure to try to answer this on your own before you hear what I say, okay? So, Darlene was driving along a country road when she saw it, the perfect horse she'd always wanted as a young girl, and naturally she needed to text her best friend to convey her excitement. As she was typing, she drove off the road and through a fence. A piece of that fence pierced her windshield and through her shoulder. Fantastic. By the time she was taken to the ER, she had lost quite a lot of blood. Normal saline solution was administered to bring her blood volume to normal. After a short time, alarms sounded as her oxygen levels had reached dangerously low levels. Why might this be? What part of whole blood was affected to cause this? So, here's a situation where someone got injured, they had a hemorrhage, they lost a lot of blood, she got to the hospital, and some inept doctor or nurse decided they needed to bring her blood volume up, so they applied saline solution. They administered that, which did bring her blood volume up, but that was definitely the wrong course of action. So, even though her blood volume was brought up by the saline, why is this an issue? What's happening here that's causing the oxygen levels to drop? Well, when she lost blood, she lost whole blood. She lost a little bit of everything, or probably a lot of everything. And when you're adding saline, really all you're doing is bringing the plasma volume up. You're not doing anything to replace all of the formed elements or any of the other things that might be in her blood. So, what's actually happening is her hematocrit is dropping. She's losing whole blood, but you're only replacing the liquid portion of blood. You're not replacing the lost erythrocytes. So if she doesn't have adequate hematocrit, then she's not going to adequately be able to carry oxygen. So that's what's going on here. The better course of action would be to apply whole blood, administer whole blood, not just the liquid saline solution. All right. So we're going to wrap up today. We're going to talk about all of the rest of the parts of blood, and then we're going to talk about blood clotting. So our next thing, we're going to talk about white blood cells, which, just like red blood cells, it was better to call them erythrocytes. White blood cells are actually called leukocytes. Leuko means white, and again, cyte means cell, so these are white cells or white blood cells. And we see a microscopic image here that has been very, very heavily modified to point out the different structures of this cell. Now, while all red blood cells, erythrocytes, look pretty much the same, there's going to be a lot of variation among leukocytes because there are a lot of different types of leukocytes. But they have some things in common. They all have amoeboid movement, which you may be familiar with, you may not. But amoeba are little single-celled organisms that you may have looked at in high school. They look like little blobs, and they crawl around on the slide when you're looking at them. And leukocytes do the same thing. Leukocytes move around, and actually once they're in your tissues, they move around through the tissues. And they do that using something called amoeboid movement. It's a good idea, if you're not familiar with this, maybe do an image search of amoeba or amoeboid movement, or even white blood cell movement and look for a GIF or a video of that, and you can see what this actually means. So, they also exhibit something called positive chemotaxis. Well, chemotaxis really means movement in response to some chemical. Now, there's lots of different chemicals that can cause chemotaxis. This is just a generic term. Chemotaxis is movement in response to a chemical. Positive chemotaxis means something moves towards certain chemicals. If it were negative chemotaxis, it would mean they move away from it. But leukocytes exhibit positive chemotaxis. They move toward certain chemicals. We will go into that in a little bit more detail when we get to the immune system. Normal levels are 5,000 to 10,000, and really different sources will give slightly different numbers than that. It may be a little bit lower, a little bit higher, but it'll always be in that ballpark. So if you're looking in a different textbook, you may see something like 4,800 to 10,500 or something like that, but it'll still be in this ballpark. Now, if you have significantly more leukocytes, it's called leukocytosis. And this is something diagnostic that can be used because normally white blood cells don't divide. Remember we said that formed elements are amitotic for the most part? Well, leukocytes typically don't divide. But in certain situations, they do. And when they do divide, there will be more of them. So you will have a higher number of leukocytes, and that's called leukocytosis. Why might that be of medical interest? Well, the things that cause leukocytes to go through mitosis and increase in number is something like an infection. So if you go to the doctor, you feel sick, and they don't really know what's wrong with you, they may do a blood draw. And when they look at your leukocytes, if they see that your leukocytes are elevated, if you have leukocytosis, that tells them, oh, chances are this person has an infection somewhere. Because it is an infection, typically, that causes leukocytosis. Now, when we look at these under a microscope, they will look very, very different. There's several different types, and there's two real big categories. Some of them are going to have what looks like polka dots in their cytoplasm, and some of them won't. Well, those polka dots are called granules. And granules, really what they are vesicles filled with different enzymes, different proteins. So if you can see the granules really, really well, if they look polka dotted, we call those granulocytes. Now, if you look and you don't see granules, they're called agranulocytes. So granulocytes look polka dotted. Agranulocytes do not. Now there's a phrase down here, never let monkeys eat bananas. Well, let's look to see the different types of leukocytes. And this is a chart, it's really two charts together from page 689 and 690 of your textbook. And what we can see here are the different leukocytes. We have neutrophils, eosinophils, basophils, lymphocytes, and monocytes. Now, in your outline, I've got room for you to take notes. I'm not going to go through everything because that's mostly self-study. Really, it's just a matter of writing down what do they look like to you. But I do want to point out some things that will be helpful for both lecture and lab. And one is these over here on the left. In neutrophils, there's these kind of pinkish, sometimes under a microscope, they almost look almost orange, salmon colored, but there are granules there. Eosinophils have really bright red granules, and basophils have really, really dark purple, almost black granules. And when you look at the nucleus, a neutrophil, the nucleus has many lobes, lots of different lobes. Typically, 3, maybe 4 lobes. An eosinophil under a microscope typically will have 2 very obvious lobes. If you're at all a comic fan, I always say that eosinophils look like Deadpool or Spider-Man. 2 really big things that look like eyes and a very red face. Now, neutrophils and eosinophils can often look alike, so as far as color goes, what I say to do is look at the nucleus, and eosinophils will practically always have 2 lobes of a nucleus. Neutrophils will typically have 3, 4, maybe 5 lobes. And basophils, here the granules are so dark we don't even see the nucleus. Now the nucleus is kind of U-shaped, kind of shaped like a bean almost, but we don't see it because it's hidden behind all of those granules. Now over here, neutrophil, eosinophil, basophil, all of those are granulocytes, and they all end in phil, P-H-I-L. Now over here on the right, we see lymphocyte and monocyte, and they do not have granules, or their granules aren't dark enough to be seen. So lymphocytes, the nucleus is really, really big, and under a microscope, basophils and lymphocytes will often look really, really similar. But in a basophil, what you're really seeing are those granules. In a lymphocyte, what you're seeing is the nucleus, and the way to tell them apart is a lymphocyte will have a really, really small halo of cytoplasm off to one side that's a very, very pale blue. So that's how to tell them apart. And monocytes, they're obvious because they've got this really big kidney bean-shaped nucleus. Now, the nucleus of a monocyte and a basophil look very, very similar, but we don't see the nucleus in a basophil because those granules hide it. In a monocyte, that nucleus is really, really obvious. So, over here, these are agranulocytes, and they end in cyte, monocyte and lymphocyte. So granulocytes end in phil, agranulocytes end in cyte. And you can tell them apart by looking at their nucleus and their granules. As far as what they do, I will let you guys read about that on your own and have that as part of your self-study fill out. Okay? But let's go back to Never Let Monkeys Eat Bananas. What is that? Well, that is how to tell which are the most abundant leukocytes and which are the least abundant. This is in order from most to least abundant. Never Let Monkeys Eat Bananas, neutrophil, N, lymphocyte, L, monocyte, M, eosinophil, E, basophil, B. There are more neutrophils than any other type. Next most is lymphocytes, all the way down to there are fewer basophils than any other. Okay, so Never Let Monkeys Eat Bananas, just tell us the order from most abundant to least abundant. Let's look at leukocyte production. And leukocyte production is called leukopoesis. Remember, erythrocyte production was called erythropoesis, and whole blood production was called hematopoiesis. But leukopoiesis is specifically the production of white blood cells, leukocytes. And it is under the control of a few different chemicals, specifically something called interleukins and colony-stimulating factors, or CSFs. And these are produced a few places in your body, primarily something like the thymus, the lymph nodes, and by other white blood cells. But a few other places in the body make them also, and these cause leukopoiesis. Leukopoiesis occurs in the red bone marrow, beginning with a hemopoietic stem cell or a hematopoietic stem cell, hemocytoblast, the same stem cell that caused erythropoesis. And what we're going to see now from this point forward is all of the formed elements come from the same stem cell. They come from that hemopoietic stem cell, that hemocytoblast. Now, just like we saw with the erythrocytes, there's going to be a step-by-step, and we're going to look at something called colony-forming units. And once these leukocytes are made, they're actually not fully ready to go into circulation. Some of them will remain in the red bone marrow and finish up the process. Some of them are going to go to other places in your body to finish up the process. And we will look at what that really means when we get to chapter 21, immune system. But here's a big, intimidating looking chart from page 692 of your textbook. And again, just like we saw with erythrocytes, most of this chart you do not need to know. But here's what I want you to know. You start with a hemopoietic stem cell, just like we did with erythrocytes. Then we move to colony-forming units. And there's different colony-forming units. The different colony-forming units will result in different types of mature cells. You do not need to know the different colony-forming units. Just know hemopoietic stem cell. If we're going to make leukocytes, the hemopoietic stem cell divides. One of them remains a hemopoietic stem cell. One of them becomes some type of colony-forming unit. The colony-forming unit then goes through some changes, and the end result are those individual different types of white blood cells. Now down here you will see B lymphocyte, T lymphocyte, NK cell. Don't worry about those yet. Just collectively, these are all lymphocytes. We will learn about the different types of lymphocytes in the immune system. So, begin with a hemopoietic stem cell, then we go colony-forming unit, then we go actual leukocyte. Moving on to the last of our formed elements, thrombocytes. Now, platelets are actually called thrombocytes. So now we've talked about red blood cells are erythrocytes, white blood cells are leukocytes, and platelets are thrombocytes. And we said that platelets, when we look at blood under a microscope, platelets just look like almost like dust on the microscope slide. They're just little flecks in the background floating along in the plasma. And they are produced similar to what we saw with the previous cells. We actually begin with a hemocytoblast, a hemopoietic stem cell. That goes through a division. One of those cells stays a hemocytoblast. One of those cells becomes something called a megakaryocyte. Megakaryocytes here goes on to extend parts of it into blood vessels. We can see here's the megakaryocyte. Here it's extending bits of itself into the blood flow. And then pieces of that megakaryocyte break off. And those pieces that break off, just little flecks of cytoplasm basically, are platelets. So their function, the function of platelets, is something called hemostasis. Hemostasis. Now that looks a lot like homeostasis, the word we've talked at length about in Bio 137 and have already mentioned a little bit here in Bio 139. But hemostasis is different. Hemostasis is the term for blood clotting. Now this is not agglutination, the clumping that we saw with incorrect blood group mismatches. Blood clotting is what happens when blood starts to solidify in order to keep from bleeding. So hemostasis is the function of platelets or thrombocytes. Now, How does that occur? I'm actually going to present the steps of hemostasis really different from the way your textbook does. Your textbook goes into a lot more detail than what you really need to know. I'm going to narrow it down and make it much easier to understand, I believe. And there are 3 main steps of hemostasis. And what we're going to see is what happens when you get damage to a blood vessel. So you get cut or somehow a blood vessel gets damaged. And that's what we see here in the top image. This blood vessel has a tear in it, so you're going to start to bleed. We need to stop that bleeding. And the first thing that happens when there is damage to a blood vessel is something called a vascular spasm. And this actually is the result of damage to smooth muscle. When smooth muscle gets damaged like this, it goes into these weird spasmic contractions, and it causes this blood vessel to squeeze in on itself. If this blood vessel squeezes in on itself, it's basically pinching this cut shut. Now that doesn't fix anything. That's just taking this cut and pinching it. The cut's still there, it's just pinched shut. So the second thing that happens is something called platelet plug formation, or sometimes you'll hear it called a temporary band-aid. So this is how do we plug up that cut after it's been pinched shut? Well, platelets themselves normally are not sticky. We don't want them sticking to stuff. But when we damage a blood vessel, we expose stuff that's normally inside the wall of that blood vessel. Think back to Bio 137, the different tissues that are in a blood vessel. Well, there's collagen in that blood vessel because of the elastic connective tissue. There's collagen there, and those collagen fibers, when we tear this blood vessel open, the collagen fibers are exposed. And collagen alters platelets. It causes them to become sticky. And von Willebrand factor, which is from the plasma, will cause these platelets to grow pseudopods. And not only do they stick to each other, they stick to the collagen. And the von Willebrand factor helps bridge between the collagen fibers and the platelets. They're sticking to each other, they're sticking to the collagen, they're starting to have bridges formed to hold everything together. And now we're going to go into a positive feedback loop. Search your memories of Bio 137 when we talked about feedback loops. We said almost every feedback loop in the body was a negative feedback loop. There were only a couple of positive feedback loops. You probably talked about pregnancy, and another is blood clotting. So let's look to see what this positive feedback loop is. Once these platelets get hung up in the collagen, we're going to start to release ADP, adenosine diphosphate. And the ADP is going to cause more platelets to come. And when more platelets come, they're going to get caught in that growing mass of platelets and collagen. And then they're going to release more ADP, which causes more platelets to come, to get caught, to release more ADP, to cause more platelets to come, to get caught, and that's our positive feedback. The more platelets come, the more ADP is released. The more ADP is released, the more platelets come. So it's causing a positive feedback loop. It just keeps magnifying and magnifying. Also, we're going to start to release serotonin and something called thromboxane A2. Thromboxane A2 is something called an eicosanoid. Serotonin is a neurotransmitter. Serotonin causes that spasm that was occurring up here in step 1. It causes that spasm to be enhanced. It squeezes even harder. And the thromboxane A2 causes even more platelet aggregation. It causes more platelets to come and get stuck. So again, we've pinched this vessel shut. We've thrown platelets into this and they started to clump together, but we still haven't really fixed anything. This is just squeezing a hole shut and throwing some stuff into it. It's not fixed the problem. We need to be able to fix the problem. And really, even though I've divided this into 3 steps, the vascular spasm, the platelet plug, and the next thing, the fibrin clot, they do happen in this order. The vascular spasm happens first, the platelet plug starts happening after that, the fibrin clot starts happening after that, but by the end, they're all 3 happening. It's not one starts and the next stops. It's all of them are happening by the end of this. So we're going to actually look at the fibrin clot formation, like I said, very differently from the way your book presents it. And we're going to draw a flow chart. So what we see here, this is going to be a flow chart. And I like to draw flow charts because it kind of shows you step by step how things are happening. And this causes this to happen, which causes this to happen. And what I've got here, if you like to draw along or write along with me, this is going to be a flow chart for how the platelet plug is, how the fibrin clot is actually formed. And what we see here is some stuff that's in the plasma, normally not doing anything. And that's a trend that we're going to see a lot this semester, is I'd say probably 7 or 8 times, we're going to see stuff that's in the plasma, in the blood, not really doing anything until it's activated. And that's what we see here. And I've got it drawn this way for a reason. So if you do like to draw along, you'll want to write these things the way that I have them here. And what we see first is calcium, PF3 or platelet factor 3, and procoagulants. Now procoagulants are all of those things that in your textbook have all those different Roman numerals, several different confusing names, but I'm just lumping them all together and calling them procoagulants. And they're made by the liver and released into the plasma, and they're just circulating. We've also got something called prothrombin and something called fibrinogen. And remember, fibrinogen, we saw it back when we were looking at the different proteins in the plasma. Fibrinogen was one of the big ones. So let's look at what happens when there is some sort of tissue damage. Okay, when there is some sort of tissue damage, in addition to what we've already seen with the exposure of the collagen fibers and the vascular spasm, we're also going to have that tissue release something called tissue factor. Tissue factor, TF. Now, when tissue factor is released, and remember, it should only be released if there's tissue damage. Tissue factor interacts with the calcium and the platelet factor 3 and the procoagulants. And together, they're going to create something called prothrombinase. Prothrombinase. Now, prothrombinase should only be there if tissue factor was there, and tissue factor should only be there if there was tissue damage. So, prothrombinase, you've probably never heard of it, but I bet you can tell me something about it even though you haven't ever heard of it. What's something you can think of about this? It's an enzyme. How do we know that? Because almost without fail, enzymes will tend to be ACE. At the end, we're going to see ASE. And enzymes, remember, are proteins that cause a reaction to occur without becoming a part of the reaction or changed by the reaction. So what does prothrombinase do? Well, it starts to build up locally where that damage was because the tissue factor is only being released locally. And the tissue factor, as it builds up locally, it creates prothrombinase, which is now building up locally. And as the prothrombin, passes by in the bloodstream, some of it is grabbed by the prothrombinase, and the prothrombinase converts prothrombin into something called thrombin. This little fishhook, what that means is the prothrombinase takes the prothrombin and turns it into thrombin, and the prothrombinase leaves, and it is still exactly the way it was to begin with. The prothrombin was converted into thrombin, but the prothrombinase did not change. It's there to do it again. So now we have thrombin building up locally, and to go back, we shouldn't have thrombin unless we have prothrombinase. We shouldn't have prothrombinase unless we have tissue factor. We shouldn't have tissue factor unless we had tissue damage. So thrombin, what is it? Even though it doesn't end in ACE, it's another enzyme, and it's building up locally. And what it does is fibrinogen, as that cycles by, as that flows through in the bloodstream, thrombin takes fibrinogen and converts it into fibrin. Well, fibrinogen is a very soluble protein. It's dissolved in the blood plasma. But fibrin is not soluble. It's a very long thread-like protein that settles out of the plasma. But it's very local. All of this is happening in the area where the tissue damage occurs. So as fibrin builds up, what's going to happen? It's this long thread-like protein, and it's going to get caught in that big growing mass of platelets and collagen fibers. And the more fibrin gets caught, it's going to start to create almost like a net. And that big net is going to catch more platelets. It's going to catch leukocytes. It's going to catch erythrocytes. It's just like if you put a dam a net in and start letting, all the stuff in the water flow through. It's going to basically create a dam. It's going to catch a bunch of, pebbles or whatever happens to go by in this water. And eventually, this fibrin is going to start to harden. It's going to do what we call retract. And that will lead to what we typically call a scab. So the fibrin should only be there back, if there was tissue damage. We only want a clot to occur if there was tissue damage. And the tissue damage is what caused the tissue factor that set the whole thing in motion. All right. And this is what we see here. This is an actual blood clot in process. These stringy things, that's the fibrin. But now we've patched up that vessel. We've actually fixed the problem, but how do we regrow the vessel? How do we make sure that that vessel is healthy again? Well, that's going to be under control of something called platelet-derived growth factor, or PDGF. Platelet-derived growth factor causes regrowth of blood vessels. Either a damaged blood vessel will regrow the damaged portion, or in some cases it will cause entirely new blood vessels to grow. An interesting sidebar with this is tumors will often learn to release platelet-derived growth factor. Well, tumors, when they're slowly growing, as they reach a certain point, all a tumor is just a part of your body that's growing when it shouldn't be. So it needs a lot of energy. And if it can release platelet-derived growth factor, what's going to happen? New blood vessels are going to grow, and they're going to grow towards that tumor. And once that tumor has an elevated blood supply, now it has a lot more energy that it can start to grow much faster. So some tumors will release platelet-derived growth factor in order to increase the blood supply so that it can grow even faster. Well, like I kept saying, that clotting, we only want it to occur when there's damage. And we also want it to remain very, very localized. We don't want that clot to just keep growing and growing and growing. So what keeps that clotting in check? Well, normal blood flow. As long as our blood is circulating appropriately, let's go back to our flow chart. That tissue factor is going to be swept away. The prothrombinase is going to be swept away. The thrombin is going to be swept away. So all of these bits and pieces that cause the next step to occur, they're building up locally, and that's where the clot is. But if there's too much, it's just going to get swept away before it can cause that clot to get bigger and bigger and bigger. So normal blood flow. Also, prostacyclin and nitric oxide, those are released from healthy tissue. So not damaged tissue, but healthy tissue. And they prevent aggregation of platelets, which is what we would want if we don't need a blood clot. But sometimes blood clotting does not go the way we want. There are some disorders involved with hemostasis. Sometimes we will get abnormal clotting, called thrombosis, clotting when we don't want it. And if a thrombus starts to grow, well, a thrombus is just clotting on the wall of a vessel that does not have damage. If there's one, it's called a thrombus. If there's more than one, we call them thrombi. So that's just singular and plural. A thrombus is a blood clot on a vessel wall. Now, those are dangerous because they can break off and go into circulation, in which case we call it an embolus or emboli if there's more than one. An embolus is just a circulating clot. And these are really problematic because as we get further and further and further away from the heart in circulation, the blood vessels get smaller and smaller and smaller. And if this clot is big enough, it can get caught in a small vessel. And then we have an embolism. And embolism is a problem because if we have that small blood vessel blocked off, then the blood vessel is going to start to swell and eventually pop like a balloon. And that can lead to something like a stroke if it occurs in the brain, or a heart attack if it occurs in one of the small vessels of the heart, or all kinds of problems depending on where it occurs in the body. So to prevent that, there's classes of drugs called anticoagulants. Anticoagulants prevent blood from clotting when we don't want it to happen. One common anticoagulant is aspirin. And aspirin prevents thromboxane A2. So let's go back again. Thromboxane A2, oh, that was not on here, I'm sorry. Thromboxane A2 is what caused the platelet aggregation. So if we prevent thromboxane A2, we don't get the platelet aggregation, so that platelet plug is reduced. Heparin blocks thrombin, and that's what I'm looking for here. So heparin blocks thrombin. And if we don't have thrombin, we will not convert fibrinogen into fibrin. Warfarin, or Coumadin, which rat poison, they're all three the same thing. Warfarin, Coumadin, rat poison, they block vitamin K from being taken up by your liver. Why does that matter? Well, the liver is what makes these procoagulants. And the liver needs vitamin K to make those procoagulants. If we block that, then we don't make procoagulants, we don't make prothrombinase, we don't make thrombin, we don't make fibrin. And now, what we were just describing when we were talking about a blood clot, it seems as though we're talking about, you cut your hand or something like that. But reality is we are constantly damaging our blood vessels. Most of them are very, very small, microscopic, but they are constantly being damaged and they're constantly being repaired. using that step-by-step process that we just saw. Now, the way rat poison works is it blocks that whole fibrin clot formation, and the rats will bleed out. So if someone's taking one of these drugs, in a controlled fashion, it prevents clots from forming on a big scale when we don't want them. But the danger is it can prevent those small clots from forming when we do want them. So you have to be very, very careful. But if someone is ever killed by rat poison, that's what happened. They're starting to bleed from all these little micro tears that aren't able to be repaired. Thrombocytopenia is a disorder when there are not enough platelets. And what we will see is something called petechia, and that's what we see right down here. Petechia are these small red spots on the skin, and everyone has some small red spots on their skin, so don't freak out and think that you have this just because you have some red spots. These almost look like a rash. It's several of them, and what this is just bleeding under the skin from what I just talked about. If you're bleeding under the skin, you get a bruise. But if you're bleeding from these small micro tears, then you will have these petechia. And that is because you don't have enough platelets. Impaired liver, so if you have liver damage, or if you have a vitamin K deficiency, well, that would be the exact same thing as if you had rat poison. If you don't have vitamin K being accessed by your liver, or if your liver is unable to process that vitamin K in order to make procoagulants, then you can't prevent those small tears with small blood clots. Hemophilia. Hemophilia is actually a class. There's different types of hemophilia, but really what it literally translates into is love to bleed. And this is an inability to stop bleeding. And the reason I have Ryan White here, typically now my students are far enough away that they're so young that they don't know about Ryan White. I always enjoy when I have some older students in my class that are old enough to remember the 80s when Ryan White was a very big name. And Ryan White, if you're not familiar, was a young boy in the 80s, and he was a hemophiliac. And the treatment for hemophilia is regular blood transfusions so that you can have platelets replaced, so that if you get a cut, you don't bleed to death, because that is a real problem with hemophiliacs. Are small cuts that really would not be a problem for anyone can be fatal for a hemophiliac. So they would regularly go and get these transfusions. Now, Ryan White was a hemophiliac, and he would go and get these transfusions. But this was before the time that the AIDS epidemic was really getting a lot of attention. And HIV, AIDS, the virus that causes AIDS, wasn't scanned for in blood that was donated because it hadn't gotten the attention yet. And Ryan White went to get a transfusion, and the blood that he was transfused with had the HIV virus. And Ryan White developed AIDS as a result. And that is what brought all of the attention to the AIDS epidemic in the 1980s. So Ryan White did end up dying from AIDS because he received it in a blood transfusion. So that is the end of our first chapter. And next, we're going to talk about the cardiovascular, which is actually 2 chapters. And it's chapter 19 and 20. But if you look at your outline, what we actually do is we begin with a little bit of chapter 20. We fall back and we cover all of chapter 19. And then we jump ahead again and cover some more of chapter 20. So the order that it's in the outline is the order that I will cover it in lecture. All right, I will talk to you soon.